Well, hello there. Thank you so much for studying with me today. We'll be talking about the exemplar of asthma. So grab your notes, grab your textbook, and get ready to study along. Now, the pages for the slides won't be on the video, but they will be available on Blackboard in the PDF of the PowerPoint slides, so you can find those there. Let's get started. So asthma is one exemplar that we discuss as it pertains to gas exchange because it's one of the most common and prevalent respiratory illnesses that we see in our country. It affects approximately 18 million people in the US, 6 million of those being children. And about 8% of kids and 8% of adults have asthma, whether it's mild or moderate or severe. In adults, it's more common in women, and in children, it's more common in boys. Now, there are certainly risk factors for asthma. Family history is a high risk for having asthma yourself. Someone who has frequent respiratory infections that cause lots of inflammation in the lungs can lead to asthma. Patients with eczema, because eczema is an inflammatory response of the body, and we see it, in a skin rash, but we're also going to see that inflammation, that tendency to have inflammation that can show up in the lungs as asthma. Patients who have seasonal allergies or allergies just in general, again, are just kind of at higher risk and predisposed to having more inflammation in their body, and asthma is an inflammation of the lung tissue. And then people who are Black, Indigenous, or people of color are all at higher risk and actually have a higher morbidity and mortality from asthma as well. So like I said previously, at the heart of it, asthma is an intermittent, on and off, reversible airway obstruction that is caused from inflammation. So it's inflammation of the lung airways and the lung tissue that tightens the muscles around the airways and causes obstruction so that we're not able to get good airflow in and out of the lungs. Not only that, but the bronchioles, the lung tubes, are hyper-responsive. They are very easily irritated by different environmental stimuli and can become inflamed quite easily. So if you've ever seen on the news how they talk about a high pollution day or high fog day, smog day, days like that can cause asthmatics to have irritation in their lungs and then more inflammation because they have that hyper responsiveness to stimuli that can irritate it. So we know that asthma is an inflammation of the lungs and the airways of the lungs. But let's talk about how that happens. Asthma exacerbations or acute occurrences are always caused by some kind of trigger, and that trigger could be something like secondhand smoke, it could be exercise induced, it may be allergy induced. There can be lots of different irritants that are going to trigger asthma for patients. That trigger then causes the body to have that inflammatory response. That inflammatory response, as part of that, causes the capillaries and blood vessels in the lungs themselves to become dilated, larger, and leaky. And so we get edema, swelling in the lung tissue because of those leaky vessels. It's all part of the inflammatory response. In addition, we're going to have excess mucus production. So we have our airways that are clamping down because they're inflamed and they're filled up with gunk. So could you imagine, we've got normal, nice, lung pipes, airway, we move our air through these pipes. These airways are swollen, so they're tight and small, and then they're filled up with gunk. And so the ability to move air in and out of the lungs becomes problematic. So then the airway is thickened and the bronchioles are continued to be hyper-responsive. So they're going to continue to be irritated, and we just get into this vicious cycle until we can break it. So asthma at its core is inflammation of the lungs that causes edema and swelling in the airways, excess mucus, and then difficulty breathing because the airways are so tight, small, and inflamed and full of mucus. So when we see a patient who's having an asthma exacerbation or an asthma attack, we're going to hear wheezing because the airways are constricted. And so we're going to hear the movement of the air through these smaller, tighter airways. They're going to have dyspnea. Dyspnea means shortness of breath. They may be speaking in short sentences. They may be coughing. They get kind of a bronchospasm, and it causes them to cough. They may have increased sputum because they have mucus in their airways, and we're going to see their respiratory rate be elevated and have tachypnea. So diagnosis for this is going to be based on the patient's own history and report of their own shortness of breath, what things trigger their shortness of breath, a chest x-ray, pulse oximetry. We should see a patient's pulse ox be lower when they're having an acute exacerbation of asthma. And then, of course, we can always check their arterial blood gas as well, looking for respiratory acidosis usually. And then we can perform pulmonary function tests. Now, pulmonary function tests are a combination of different tests that can be done to evaluate the functioning of someone's respiratory system, where they do things like blow out all of the air that they can in 1 second and see how forceful that they were able to expel that air. So that would be called the forced expiratory volume in 1 second test. And so we are going to learn about a peak flow meter later. That's something that patients can do at home to kind of evaluate their own respiratory function on a day-to-day basis. Now, because asthma is a chronic condition, we want to make sure we've got good control for these patients over time. And that means really partnering with patients because they're not always going to be in the hospital. In fact, we'd like to keep them out of the hospital and managing this at home. And so when they do come in, we need to do good respiratory assessments to make sure that we're not missing anything. Monitoring their symptoms over time, asking how they're doing and if their condition is improving or getting worse over time. Teaching them how to control environmental factors. One of the things we always tell patients who are asthmatics as kids, we tell their parents, like if their parents smoke, that they need to have a smoking jacket. They need to not only go outside to smoke, but they need to sort of put a certain jacket on that jacket only stays in the garage and that's what they smoke in, and then they take it off before they come back in the house, because that secondary smoke, even on the parents' clothes, can trigger an asthma exacerbation. So that's one example of controlling environmental factors. Another thing would be making sure patients always have their inhaler with them when they're performing exercise, and avoiding, high pollution days. If it's a high pollution day, it might not be the best day to go for a hike. Of course, there's medications we use for asthma treatment, both for long-term control as well as rescue medications when someone's having an acute exacerbation, and then lots and lots of patient education and family education to have good control over time. And we're going to talk about some more of these as we go along. So one of those assessments I mentioned was a peak flow meter, and I've put a link here, it'll be in your slides as well as down in the description box on YouTube, on how to use a peak flow meter. But essentially, the patients are going to use this 1, maybe even 2 times a day at the same time every day. They'll slide the arrow back down to 0 to get started. And then they will take a nice deep breath, stand up straight, close their lips over the mouthpiece, and blow hard and fast as much as they can. Then they're going to note their number for that, and they're going to repeat that 2 more times. They will record their highest number of 3 attempts. And everyone's peak flow and their good, healthy range is going to be dependent on them. And so their provider will have already established with them, what a healthy, safe range is for them, what their yellow zone might be, and then when they're really having trouble in a red zone. And so we want to make sure that they're in the nice green zone, and that way they know that they're, in a safe spot at that time. So that's a peak flow meter. The next thing we want to talk about is a metered dose inhaler. Typically, we just call it an inhaler. Metered dose just means that it has a little number on it, and every time you pump it and use one of the doses, that number goes down and they can see how much is left so that they don't run out. So again, there's another link in the description box on how to use a metered dose inhaler. But essentially, they take the cap off and they shake it, take a deep breath out, close their lips around the mouthpiece, start to breathe in slowly and deeply, and then press the canister down, continuing to take that nice deep breath. Once they've taken the full deep breath, hold that breath for 10 seconds and then breathe out slowly. That's the key, is we want to keep that dose in their lungs for the full 10 seconds before they breathe it back out. If they're supposed to take more than one puff, then they would need to wait about a minute between puffs. If it's a steroid inhaler, a corticoid steroid inhaler, they'll want to rinse their mouth out to avoid sores in the mouth that could happen. And at the end, they, of course, replace the cap. And then finally, for some patients, we use a metered dose inhaler with a spacer. And in fact, it's really preferred for all patients. It's very hard to coordinate the taking the breath while depressing the canister and really ensuring that you're getting the full dose. So we recommend that patients get these spacers that look like this down here. And it just attaches to that regular metered dose inhaler. This inhaler goes on one side, the patient uses their mouth on the other, and that the depressed medication kind of hangs out in this space for a little longer, so that patients make sure that they get the full dose and that they don't have to coordinate that breath as closely. So again, it's pretty much the same routine. Remove the cap, shake it 10 to 15 times, put the inhaler on the spacer, and then put their lips around the mouthpiece of the other side. Depress the canister on the spacer, taking a slow, deep breath, holding for 10 seconds. Then they breathe slowly back out through the mouthpiece while they still have it on their mouth. Then taking another deep breath without pressing the canister again. So they're getting really 2 breaths with the same canister pump. Waiting a minute, then repeating if necessary. And again, rinsing their mouth if it's a steroid inhaler and replacing the cap of the metered dose inhaler. You'll see a link to a 1-minute video with a demonstration down in the description box, and I would encourage you to check that out as well. Now, there are a number of medications that we use for asthma. The most common ones are going to be bronchodilators and steroids. Bronchodilators are going to open up those airways, the airways that are all constricted and closed off. We want those to get nice and big so air can move through those again. And then steroids actually reduce inflammation. And so we're going to talk about these 2 medication drug categories today. Bronchodilators, the most common one is the albuterol inhaler. It's a beta-2 adrenergic agonist, which means it works on the beta-2 receptors in the lungs to vasodilate, dilate the lungs itself, the airways of the lungs. So these bronchodilators are going to dilate the airways of the lungs. This can be given either through a metered dose inhaler that patients will bring around with them, or even through a nebulizer treatment. The side effects are tachycardia, insomnia, and tremors, because these beta-2 adrenergic agonists work on the beta-2 receptors of the lungs, but they also work on the beta-1 receptors of the heart, which causes tachycardia, can make you feel like you've had about 5 cups of coffee, and then therefore make you feel like you have a hard time sleeping. So those are some of the side effects to look for, especially if patients have needed a few doses. So we're going to see tachycardia, jittery, hard time sleeping. And then we want to encourage patients to avoid beta blockers, because beta blockers will block the effect of albuterol. So if a patient really is going to need albuterol and they're having an asthma attack, if they're on a beta blocker, the beta blocker is blocking the albuterol, and we want to avoid that. So that would not be a good medication for those patients to be on. Okay, so those are bronchodilators. The second medication category we're going to talk about here is anti-inflammatories, and specifically corticosteroids. The most common ones are going to be either solumedrol, which will be given IV push, or prednisone, which can be given orally. The side effects of steroids in general include oral thrush, if it's a inhaled corticosteroid, like an inhaler. So that's why we encourage the patients to rinse their mouth out after every use and wash their inhaler at least 2 times a week. And steroids are anti-inflammatories. They reduce inflammation, but they also have a couple of side effects. Specifically, they reduce our immune response. And they increase blood sugar. So those are some side effects you can see with long-term use of steroids, that the patients are at higher risk for getting sick and having sepsis, and they also are at higher risk for having elevated blood sugar due to the steroid use. So asthma can be fatal, and patients need to kind of know when they're at risk in the red zone and things are not going well and they need to get additional help, and when they can manage things at home. And the fatal complication of asthma is status asthmaticus. It just means they're having a really, really severe exacerbation, and everything gets so tight that they become hypoxic and eventually leads to respiratory failure, where they have no movement of air anymore. If you're auscultating the lungs of an asthmatic, hearing someone who's nice and loud and wheezy is actually way better than hearing someone where you're not hearing much at all, because they're so clamped down that they just are not moving air. And so in a status asthmaticus, these patients need to be in an ER, and there's additional medications that we'll do in an ER, including continuous nebulizer treatments, one after another, close monitoring with pulse oximetry and cardiac monitoring. And we'll even give magnesium IV to help relax the muscles in the chest and help them to take better deep breaths. And if that doesn't work, then patients may have to be intubated and put on a ventilator for a few days until we can get them over that exacerbation. So if patients are having a really acute attack, they need to be brought to an ER, and they need to do it right away. So status asthmaticus is someone who is unresponsive to typical rescue treatment. So their inhaler is not working at home. Their nebulizer treatment is not working at home. And we're going to see those same, signs and symptoms that we have with our typical asthma patients. They're just going to be worse. Bronchospasm, inflammation, increased mucus. The patients will complain of chest tightness, wheezing. They'll have this dry cough from the bronchospasm. They'll have shortness of breath, severe respiratory distress. They may appear very anxious. They may be diaphoretic. They may not even be able to speak more than a word or two. And this can be life-threatening if interventions are not done swiftly. As always, let's walk through the nursing process as it pertains to asthma. Now, in terms of assessment, the types of signs and symptoms that you're going to notice if you think someone's having an asthma attack are going to be their vital signs. You're going to want to watch their O2 saturation, looking at their blood gas level. How are their breath sounds? Do they sound wheezy? Are they awake and alert? If they are not awake and alert, it could be that they're so hypoxic and they're not moving any air so that their brains aren't getting the oxygen they need. Does the patient have the ability to speak full sentences, or are they speaking in short sentences because they're so short of breath? Do they have a dry cough? Are they using accessory muscles? So we have these muscles around our chest cavity, our intercostal muscles, muscles in our neck, and these are not typically used when we breathe. But when our body is really struggling for air, it's going to recruit any muscle it can to try to suck extra air in. And so we can see retractions where the spaces between the ribs are actually being pulled in from using these intercostal muscles to try to pull extra air in. Or we'll see nasal flaring, where the nares actually flare out every time the patient is trying to breathe, just trying to use every part of their body to take a deep breath. And the problem is those muscles will tire out. We can't use accessory muscles over time. And so, if you see someone using accessory muscle, we need to intervene quickly because they are going to tire out. We want to watch their body positioning. Are they tripoding, meaning kind of leaning forward in kind of a tripod position? And patients will do that to try to open up their lung space and get as much room in their lungs to fill up as they can when they're short of breath. We're going to watch for dyspnea, of course, shortness of breath, and we're going to ask if they've ever been intubated. So intubation, meaning having to have a breathing tube put down your throat and be put on a ventilator. If you already have been intubated for asthma, it means you have really bad asthma. It also means you could go south really quickly. And so if someone's been intubated in the past, that should give us a high level of risk and suspicion that this patient needs some help. All right, so the next step of the nursing process, as always, is nursing diagnosis. And so some nursing diagnoses related to asthma would be things like ineffective airway clearance because of all this mucus and the bronchospasm and the fatigue. Difficulty with the gas exchange, impaired gas exchange, where they're not able to get enough gas exchange, getting more oxygen to their bloodstream because they're short of breath. And they can definitely have some anxiety, not because it's a mental health issue, but because they're literally starving for air and getting really anxious about that. So as always, our nursing interventions are going to be related to 3 areas: actions to take, teaching to do, and assessments to make, but I guess we already talked about the assessments. So we'll just say actions to take and teaching to do. So if you've got a patient, you recognize they're short of breath, they're having retractions, they are using accessory muscles, speaking in short sentences, we need to take action on these guys. So our goal is to make sure that they have oxygenation of above 90%. So put them on oxygen and then administer medications as ordered. And on these patients, you can expect that they're going to be on some kind of nebulizer albuterol treatment and giving them some kind of steroid at the minimum. And then finally, teaching. Remember, teaching is so important for any of these chronic conditions that patients are going to manage at home. We want to keep people safe and healthy and out of the hospital. And so that means really partnering with our patients and providing them the resources they need to be successful. And so that means assisting with creating an individualized asthma action plan, teaching them how to avoid triggers, teaching them pursed lip breathing that can help bring extra oxygen into their lungs when they need it, making sure that they know what their regimen is for medications, teaching them how to use their inhaler properly, which is really important, teaching them how to use that peak flow meter to monitor their status at home and record those numbers daily, if not twice daily, and then of course, to quit smoking, because smoking and asthma do not mix at all. And finally, how do we know when we did a good job? How do we know that we can evaluate and say, okay, the patient's doing well? Well, a patient who's well managed on asthma is going to have decreased ER visits because they're managing mild asthma at home. They're going to have decreased use of their rescue medications because their maintenance medications are working for them. And they're going to show minimal symptoms. So these are the kinds of goals that we have for our asthma patients. And that's what you need to know for asthma. Thanks as always for studying with me, and we will see you in class. Have a great day.